known as DG Neuro. Next. Next. Yeah, so we'll have this program today. Next. DG Neuro is a digital health initiative. We have 90 plus webinars on this YouTube channel. We have speakers from 12 countries till now participated in this, and more than 1,200 neurosurgeons are subscriber to DG Neuro channel of YouTube. Next. Health and You is an organization created in collaboration with equity participation of New Link Company Limited, Japan. Next. We have some very innovative products given to you by our team. Next. Amnuride, we were the first one to combine amitriptyl plus mecobalamin for neuropathic pain and migraine. We have 5 milligram, 10 milligram, 25 milligram. We were the first one to bring amitriptyl in 5 milligram. We were the first one to bring amitriptyl plus propranolol combination amnuride beta 520 ER and 1040 ER. So that compliance is much better. You just have to give one tablet a day, and results are much better at very economical price. Next. We are the first one to give triaxiphenidil 1 milligram per ml in liquid form. To start the dose with 1 milligram, that is possible now with triazi syrup 1 milligram per ml. You can give it in pediatric, you can give it in geriatric. So liquid form of triaxiphenidil first time in India, 1 milligram per ml. Next. We have launched beta 1316 glucan for DMD, Duchenne muscular dystrophy, a rare neurological disorder. Next. On affordability, we have Icogaba NT 400, almost 1/3 the price of leading brand of Gabapin NT. Next. We have Amnuride P for moderate to severe neuropathic pain, where pregabalin in a sustained release form with amitriptyline. Next. Preride D, pregabalin plus diloxin combination, both are USFDA approved products for neuropathic pain. Next. That's about it. And over to you, the organizers, to carry on the workshop. Thank you so much for giving us the opportunity.
Thank you, Mr. Deepak, and good evening to everyone, and welcome to this INDSPN webinar. Today's top webinar is focused on diffuse midline gliomas and their management. And I would like to first welcome our two panelists, Dr. Anand Balasubramaniam, Professor and Head Neurosurgery in Amrita Hospital in Faridabad, and Dr. Uday Krishna, who's a Senior Consultant Radiation Oncologist from Apollo Proton Beam Center, Chennai. So this webinar will have the format of two talks. We'll start with a talk on pathology of diffuse midline gliomas. This will be followed by two case presentations, which will be discussed by residents from various institutes. And then the last talk will be by Dr. Nishant on summarizing the management and outcomes of diffuse midline gliomas. So without delay, I would like to invite Dr. Rima, who's an assistant professor at neuropathology in CMC Vellore, to give the talk on pathology and molecular profile of diffuse midline gliomas.
Good evening, everyone. Am I audible?
Yes, you are audible.
Is my screen visible, sir?
Yes, it's visible now.
Shall I start?
Yeah, you can start.
So today's talk is on diffuse midline glioma, and the term itself is self-explanatory. So diffuse means it's an infiltrative growth predominantly occurring in the midline location like brainstem, thalamus, and spinal cord. And of course, glioma, which is arising from the oligodendroglial precursor cells. So as we all know, this DMG was previously called as DIPG. So what is the better terminology to call this tumor, whether DMG or DIPG? So the older terminology is DIPG, which is a diffuse intrinsic pontine glioma. This focused more on the anatomical classification. But the newer term, which is used in the 2021 WHO, is diffuse midline glioma, H3K27 altered. And this is more of a molecular definition. So this terminology H3K27 will be frequently used in presentation. So what happened between what is the change mainly happened was in 2012, they figured out that there is a mutation in histone proteins, which is essential for the development of this tumor. So in 2016, uh, when at that time most of the tumors were classified based on their molecular profile, these tumors were called as diffuse midline glioma H3K27 mutated. But then they figured out it is not just the H3K27 mutation that is causing this tumor. There are a hell lot of other mutations also can cause this tumor. So that is the reason they proposed the new term called as diffuse midline glioma H3K27 alter. So there are three main reasons for the change in the terminology. So first thing they figured out is that there is a separate molecular driver for this tumor, that is H3K27 alteration. And that just doesn't occur in the pons alone. It occurs in pons, thalamus, and spinal cord. That is the midline location. Second, they figured out it is not just H3K27, it is other alterations like EZIP and EGFR also. And to have a unified classification with a biologically identical tumors in different locations, they proposed the term diffuse midline glioma instead of diffuse intrinsic pontine glioma. So the terminology which we frequently used in this presentation is histones. So as you can see here, this is the chromosome in which you can see the double-stranded DNA, and these yellow spherical structures are the histones. So you can see in this picture that the DNA is winding around this histone. So what is the function of this histone is? Histone is nothing but a protein that helps to keep us the DNA in a more compact form, and it gives a structural integrity to the DNA. So that is the main function of the histones. So since it is seen in close proximity to the DNA, any alteration in the histone proteins will eventually affect the DNA. And when it affects the DNA, it regulates the expression or the epigenetic modifications of the DNA occur. So this is another one pictorial representation. As you can see here, this is a cancer cell, and in the nuclei of the cancer cell is where the nucleic acid resides. So here we can see the chromosome with the DNA wound around the histone proteins. So what happens exactly in diffuse midline glioma is just there is a substitution of one amino acid to another. For example, lysine is replaced by methionine at the 27th position. So there is just a change in one amino acid. So when it happens, what normally this is how your chromatin will be very jam-packed because of the presence of normal histones. On the other hand, when the histone is mutated, you can see that the DNA is unwinding. When it unwinds, it opens up, and then it triggers a tumorogenesis. So if you can see these methyl groups on the top, this is not seen in the mutated chromatin. So whenever there is a H3K27M mutation, the methyl groups will be gone. So this methyl groups acts as an on and off switch. So if the methyl groups are present, it results in the suppression of the oncogene. On the other hand, when the histones are mutated, there will be loss of methylation, which results in oncogene expression. When the oncogene is expressed, it results in tumor formation. That is the basic molecular pathogenesis of diffuse midline glioma. So whether it is just the histone mutation that is going to cause diffuse midline glioma, no. The predominant is by histone, but there are two other mutations also. Instead of calling as mutation, the better terminology is overexpression. So EZIP is another one which has been indicated in the development of diffuse midline glioma. The third one is the EGFR alteration. And in the CNS WHO book, diffuse midline glioma is enlisted under pediatric type diffuse high-grade glioma. So is diffuse midline glioma an age-specific entity? We all know the answer is no. Though it is typically a disease of children, it can occur in adults up to 83 years of age. In this bar diagram, the blue chart indicates the frequency of DMG in children and the green one indicates it in glioblastoma. And the stacked bar chart shows in the pediatric population, brainstem location is common. However, in adults, non-brainstem location is more prevalent. And does the tumor location influence the molecular profile and prognosis of diffuse midline glioma? Yes. As we saw, there are primarily three subtypes of diffuse midline glioma, which is related to histone or an EGFR mutant or an ESIP overexpression. So, to put it all in a simpler form, if it is a bithalamic location, the proportion of the tumor, the possibility of that tumor to be an EGFR mutant is high. And why is it important to identify is we have targeted therapies for that. Another one, a newly discovered mutation is ACVR mutation. This has been described exclusively in the fonts. And to the importance of identifying this is they have a slightly longer survival. Then moving on to the histology, you can see two pictures here. The one towards the left is slightly less cellular, or on the other hand, the one towards the right is very cellular and it has high-grade features. The one thing I want to say from this is DMGs can have a histology that range from grade 2 to grade 4. And in addition to that, it can also have a wide morphological spectrum with very undifferentiated cells or epithelioid cells, and pleomorphic xanthoastrocytoma-like picture also can be encountered in a case of DMG. So herein we can see a case who presented with weakness in right lower limb with the tumor in the middle cerebral peduncle extending to the pontomedullary junction. And in this tumor, we saw features of a high-grade glioma. As you can see here, quite a bit of glial cell cellularity. And these clusters are nothing but microvascular proliferation. If you have seen this in a location other than midline, we would have called it as a glioblastoma. And then we did a H3K27ME3 stain. ME3 stands for methylation. So in the molecular pathogenesis, we saw there will be loss of methylation. So all this brown indicates normal cells showing retained methylation profile. And these are the tumor cells showing loss of H3K27 methylation basically. And this is the H3K27M positivity indicating that it is mutated. Here again, you can see a solid cystic tumor in the posterior thalamus with the solid part showing contrast enhancement. In this case, the cellularity is not that high of a high-grade glioma, but again, you can see ME3 loss and H3K27M is negative in this tumor. In such scenarios, we will go for ESIP. This is the second subtype of your DMG. In this case, it is ESIP positive. Now you can see another patient with the tumor in the bithalamic location. Compared to the first two tumors, the cellularity is similar to that of a grade 2 tumor, and there is no necrosis or a microvascular proliferation to indicate that it is a high-grade glioma. This tumor also showed H3K27ME3 loss, but it is negative for H3K27M and ESIP. However, we found an EGFR mutation in this case. So this is the flowchart which we will follow for high-grade glioma occurring in the midline. First, you do testing for an H3K27ME3. If it is lost, then go ahead for an H3K27M testing. If it is positive, it will be labeled as a diffuse midline glioma, subtype as H3K27M mutant. If M is negative, go for an ESIP biopsy. So, till now we have seen that most of the cases, around 80% of the diffuse midline gliomas will show H3K27M positive. So does H3K27M positivity is equivalent to a DMG? No, it can be seen in other tumors also. So if you can see here, the first thing that strikes us is these blue ones are all the tumor cells, which is arranged around a central blood vessel. This is what we call it as a perivascular pseudorosette. And this is an H3Me3 stain, which again shows loss of H3K27Me3. And this is an H3K27M showing positivity. So if you go by the morphology and everything, this is a case of posterior fossa ependymoma, which can also show H3K27M positivity. So we have to correlate the radiology, everything before making a diagnosis of diffuse midline glioma. And there are also few case reports that this H3K27 mutation can be seen in tumors such as reset-forming glioneuronal tumors also. So it is not equivalent to a DMT. And in very rare occasions, it can also be seen in other tumors. So if you take the CNS WHO, it has been classified now as adult type tumors and the pediatric type tumors. And in the adult type tumors, the frequent mutation is IDH. However, histones forms the predominant type of tumors in the pediatric group. And this histone mutation is generally mutually exclusive of IDH mutations. And just because the tumor is H3K27M immunopositive, we cannot label it as a DMG. And since more than around 80% of the DMGs will be M positive, it's better to do an M followed by ESIF. But in a bithalamic location, it's usually not most likely to be an EGFR altered tumor. And the histology can range from grade 2 to grade 3. Thank you.
Thank you, Dr. Rima. That is a very nice presentation and a very elaborate discussion of how the molecular pathogenesis is influenced by these mutations. So we shall take the questions at the end of the webinar. All of you can post your questions in the chat box, if any. For the next presentation, I would like to call upon Dr. Deepak Naik, who is a final year resident neurosurgery in AIIMS Bhubaneswar. So he will be presenting a case of a diffuse midline glioma, which they managed. And the case will be discussed by Dr. Anand Akash from Sri Sathya Sai Institute of Higher Medical Sciences, Bangalore. So Dr. Deepak Naik, you can share your screen.
Yes, sir. Good evening, everyone. Hope my audio is visible.
Yeah, your slides are visible. You have to put it in the slideshow mode.
Yes, sir.
Yeah, okay.
Now it is visible, right, sir?
Yes, we can see your slides. Please go ahead.
Please go ahead. Please go ahead.
Good evening, sir. So I'll be doing a case presentation on the diffuse midline glioma. So my patient is a 7-year-old boy presented with a weakness in the left upper and lower limb from past 1 month, headache from past 1 month, and deviation of angle of mouth to the right from past 1 month. History of present illness: weakness was insidious in onset, gradually progressive in the left lower limb followed by the upper limb, affecting the proximal muscle more than the distal muscle. Headache was insidious in onset, intermittent, dull aching in the left parietal and occipital area. Patient was giving history suggestive of left UMN facial palsy, where there was deviation of angle of mouth to the right side and drooling of the saliva from the left side. There is no history of seizures or behavioral abnormalities. There is no history of severe headache, vomiting, a blurring of vision, or double vision. There is no history of fever, weight loss. There is no history of difficulty in swallowing, voice changes. So summarizing my history, so it is a right-sided pathology. Here, the pathology lies from the subcortical area to the thalamus or upper brainstem area. Here, there is no seizure or any behavioral abnormalities, and there is also no cranial nerve involvement, no lower cranial nerve involvement. And here also the pattern of facial weakness is like upper motor type of weakness, and the symptoms are from past 1 month, which is rapidly progressing, which is suggestive of any neoplastic etiology. There is no features of raised ICP in this kid. So probably the lesion which we are thinking is maybe a small lesions. So based on this history, next I will be going forward to the examination of the kid. On examination, the patient was E4, V5, M6, conscious, oriented, higher mental functions were normal. Cranial nerves, first smell was normal. Visual acuity was 6/9 on both sides. Pupils were both 3 mm equivalent reactive.
Deepak, you just tell us the salient findings, the positive findings, important. Yeah.
There is grade 2 human facial palsy on the left side, sir. And in the rest of the cranial nerves were normal. On the motor system examination, the tone was exaggerated on the left side, sir. MAS grade 1, and power was 3/5 on the left upper and lower limbs. Reflexes were 3 plus in the left biceps, knee, and ankle. Plantars were extensor on the left side and flexor on the right side. There were no cerebellar signs. Sensory examination was normal. Skull and spine was normal. So, based on my history and clinical examination, my substrates involved a right corticospinal tract, probably a right-sided lesion, and human facial palsy. So, my differential diagnosis is probably a right-sided neoplastic lesion involving the gangliocapsular region above the midbrain level. So, based on the history and examination, we'll be coming to the imaging of the patient, sir.
Yeah, you can show us the image, and Dr. Anand will read the image and then give us a diagnosis, the differentials. Dr. Anand?
Yes, sir, I can hear you, sir. So, shall
Yeah.
I start, sir?
Yeah, you can start.
This is a plain NCCT head axial section.
I'll be
No,
telling
Dr.
that.
Deepak, Dr. Anand has to read it. Yeah. Yeah, please go ahead, Anand.
So, this is a plain CT image, sir, which I can see on the left side, in which there is a well-defined intraaxial lesion, which is seen on the right side. It is of mixed density, sir. The anterior and the lateral part are more hypodense compared to the rest of the lesion, and the lesion is causing effacement over the third ventricle, sir. We can see, and there is mild ventriculomegaly which we can see, but there is no evidence of any hydrocephalus. Along with that, sir, laterally we can see that the lesion is causing mass effect on the internal capsule and as well as the caudate nucleus. Medially, the lesion is causing compression over the third ventricle.
You want to go on to the MRI? Show the MRI, Deepak.
This is a T1 weighted MRI.
We show, are there any more slices available?
I see. It's a T2 weighted MRI of the patient.
Right. So, Anand, you want to see the
Yes, sir.
describe?
This
Here, sir, the lesion is hyperintense on the T2 with the cystic intensity at the anterior end of the lesion. Lesion is causing compression on the ipsilateral third ventricle, and the lower part of the lesion is extending to the upper midbrain level, sir.
And the Gado images?
This is sagittal section of the same tumor, sir.
Yes.
This is a diffusion T2 flare image. Here, the lesion is also hyperintense on the flare. The lesion is hyperintense on the flare, sir, and there is no diffusion restriction seen. Coming to the contrast, sir, the lesion is non-enhancing. The center part of the lesion is relatively iso-intense, and the peripheral is hypo-intense, and it is non-enhancing lesion. The lesion is present in the mainly in the thalamus and also involving the upper part of the midbrain. This is a DTI imaging which we had done in the patient. Here, the blue line represents the descending tract from the cranial to caudal end, and the green line represents the anterior posterior tract, and the red line indicate the tracts which are going to the opposite brain, opposite hemisphere. In this, we can see the lesion is displacing all the blue and green fibers. So the white matter tracts are displaced laterally by the tumor. So based on the
Okay, Dr. Akash, let Dr. Anand Akash say what he feels is the tumor and what is his differentials.
Sir, to me, can you go back to the T2 images?
yes.
Yeah, can you play that video?
I'll play a video, sir.
To me, it looks like a right-sided, sir, thalmopeduncular lesion, sir, which from the thalamus is extending up to the midbrain through the cerebral peduncle. One thing, and second thing is that there are various areas of, I think maybe cystic lesions, which is present anteriorly and laterally, sir. Can be seen there are no areas of diffusion restriction or any contrast enhancement. So I'll say, sir, a right thalmopeduncular lesion.
Okay. So what is your differentials? Histologically, what do you...
Sir, differentials, I like to say mostly it looks like a low grade to me, sir, because there are no areas of diffusion restriction or any contrast enhancement which is seen. Based upon the images, sir, as he told clinically, since it was a short history, on clinically it looks like a high grade lesion, but on radiology it looks to me like a low grade lesion, sir.
You're thinking of a glioma, is the...
Yes, sir. Yes, sir.
Okay, how do you approach this patient?
Sir, I'll first like to do a biopsy for this patient. Neuronavigation or a stereotactic biopsy. If it comes as a high grade, I'll directly, since there is no hydrocephalus or anything, I'll directly like to go for an adjuvant therapy. If it comes as a low grade tumor, then I'll plan for another sitting for an approach for excision of the lesion, sir.
Okay, now let's ask Dr. Anand Balasubramaniam what is his opinion, take on this image and what he would do.
Yeah, first of all, on the radiology, saying it is low grade or high grade is difficult. We all know that non-enhancement is not a marker of low grade tumor. Non-enhancing tumors can still be high grade. So you can't say it is low grade. Second, there is compression and displacement of the long tracts. If you decompress this lesion, it's likely that his quality of life is likely to improve, whether it is high or low grade, because mass effect is there on the long tracts. So I think there is a definite indication for you to decompress the tumor if it is decompressible. If it was not approachable at all, then biopsy is the only option. Wherever these tumors are approachable, I think one should make a decent attempt to decompress without causing an additional deficit. And here, as you can see in the T2 images very nicely, axial sections, the lesion is exophytic at the level of midbrain and also coming into the temporal horn, where the temporal stem is communicating with the basal ganglia. So you do have a nice entry, even though the...
Can you show the T2 image, Deepak?
Yes, sir.
Yeah,
Yeah.
yeah. You can go down to the level of temporal horn. You'll see that there is a good approach. It's on the right side. You have a direct lateral approach to reach into the lesion. And yeah, no, I think you crossed it. Yeah, just scroll a little more. Yeah, next cut, next, slowly. One more, one more. Stop, one more. Next cut, next cut. Yes, and the next cut. One more. Yeah. So in these two cuts, one cut or two cuts above this, there is a good access route. So in short, whether it is benign or I mean whether it's low grade or high grade, the resection will, if it can be done safely, I would prefer to probably go for a resection. Doing a biopsy and then deciding not to do anything if it is high grade won't be a adequate approach to the patient. I think with introp monitoring and image guidance, one should be able to do a decent decompression of the tumor. And if it turns out to be low grade, his longevity is only likely to increase. And if it is high grade, then anyway, it's going to be restricted. And we are on the topic of DMGs. So we know that histology is not of as much importance as molecular diagnosis here. And if this turns out to be DMG with the histone mutation, then there is going to be prognosis is going to be poor. But the quality of life till that time probably can be improved by decompression.
Okay, Dr. Anand, do you think if it's a low-grade tumor, usually tends to displace the nerves and everything when an exophytic component like this? But in a higher grade tumor, do you think the third nerve and other structures will be inside the tumor, and so you stand a greater chance of damaging them? And
Unlikely. We don't know. We can leave behind tumor in that direction if you do it with
okay.
monitoring and with stimulation. If you're near the third nerve, because
Mhm.
there is an interpeduncular area where the tumor is exophytic,
Yes.
probably that's where the third is getting probably affected.
Yes.
But the rest of the brainstem and the DTI, we'd like to see the DTI pictures more closely. The one that are represented are not enough to plan out a surgical approach. So we need
Yes.
to see the images more closely and clearly, section by section, not a 3D representation. And you should be able to get with proper MAP monitoring and introp deep white matter stimulation. I think we can um, at least 70 to 80% can be decompressed if they are not running through the tumor, which DTI is not showing. Yeah.
Right. So if the DTI showed that it was running through the tumor, you would just stop with a biopsy, right?
That would be yeah. So that
That
is
would be
what the original classical DIPG types
DIG
are.
plus. Yes.
If we had seen anything like that here, then we would not. I think surgery would be the futile exercise.
Yes. Okay. So Dr. Deepak, what did you all do for this case?
1 minute, Dr. Anjit. Before that,
Yeah.
Dr. Uday.
No, I think he let him give the diagnosis, then we can ask
Yes, sir.
Uday a couple.
Actually, I
No.
wanted to make a
Before the diagnosis,
Yeah.
this is a
I
point of
wanted to make
controversy
a
that 1 minute. I'll ask the question that see, like what Dr. Anand said, and many of the recent discussion in most oncology is the when we are looking at diffuse midline glioma, if it is H3K27 mutant, there is no role or there is no need to do surgery because it can add to the morbidity and does not make a change in survival, and probably that is the reason why. Uh, Deepak told, Anand told that he will do a biopsy and confirm and go ahead. So, from a surgeon's point of view, Dr. Anand Balasubramanian said that if it is decompressible and as much as possible, irrespective of whether it is a pilocytic or a high grade glioma, he would consider that. What is your opinion on that? Because
actually I
the
was also
literature differs. If you say if it is DMG, then biopsy is sufficient because surgery may not change the outcome but would add to the morbidity. What is your take on that based on literature?
yeah. So even I wanted to make a comment what Dr. Anand Akash was saying was right, meaning it is solid cystic. So solid cystic as a oncologist, I also would be happy to know if it is pilocytic. Although the enhancement in the scan is not characteristic of pilocytic with cystic and mural nodule, but still, because there's a cystic component and not just a diffuse flare abnormality, I also would be happy to do a biopsy initially, confirm what is the histology, and then proceed to further maximal safe resection or how much ever we can debulk, like Dr. Anand Balasubramaniam said. So I also would be
No, if the
wanting to do a
if the
staged
plan is
wisely.
to do decompression irrespective of the biopsy, then why biopsy?
Meaning that is with keeping with prognosis in mind, isn't it? So if suppose it comes as a favorable tumor, irrespective of these tracts and other things, what you people were discussing, I think if it comes as a favorable, if it comes as a histone altered diffuse midline glioma, then I don't think we should put the child into any more neurosurgical morbidity, is what I feel.
Irrespective of the mass effect and irrespective of a corridor that is available for a surgeon to decompress. So that is a controversy, and that is where we have to look at the literature.
Yeah, given that this is thalamic, of course, we first of all request surgeons to debulk as much as possible, meaning if it comes directly to us and not to you. But yeah, unlike the pontine gliomas, this definitely we also would push for maximal surgical resection. But like how he was saying, if it is pilocytic, then we'll be more happier to know more about it. Or if it is a low-grade glioma and non-histone driven, then it would be more convincing to also tell families that surgical, because what I have seen personally and also system here is most of the families have already sort of given up because of multiple opinions, or the primary surgeon has told them nothing is possible, this is quite grave, etc. So to motivate them to undergo a surgery from here, I think has to be backed by a biopsy which says this is a favorable situation and not a grave situation.
We'll listen to what has been done for this patient.
Yes, sir.
Yeah, please go ahead.
Dr. Deepak.
Here we had an right frontotemporal craniotomy and subtotal excision and of the tumor under IONM guidance. We had done mainly a tumor debulking. Here, since all the tracts or the white matter tracts were displaced laterally, we thought we'll go from the medially. Like we chose a operative corridor in the right superior frontal gyrus, and it was tangentially abutting the right periventricular area, directed inferiorly and medially, where subcortical stimulation was also done intraoperatively, sir. The tumor was seen approximately 4.5 centimeter deep from the cortical surface. Tumor was intraaxial, reddish gray, firm, non-suckable, and moderately vascular. Here we can see the surgical corridor which we have gone. It is from the superior frontal gyrus right side, which is directed medially and inferiorly. Here we can see the intraoperative neuronavigation probe, where we have identified the surgical corridor. Intraoperative frozen was sent, sir. It was suggestive of low-grade glioma. So ventricles were opened intraoperatively. So EVD was inserted, which was removed on the day 3. Patient had the same power of 3/5 on the left side postoperatively, and the patient was discharged with the power of 3/5 on the POD 9. This is a postoperative CT scan, which is showing the subtotal tumor residual in the right thalamic area with EVD in situ in the right frontal horn of the right lateral ventricle. We can also see some pneumocephalus in the patient scans. So this is a post of MRI which was done after 1 month of the surgery. Which also show the residual tumor in the right thalamic area, sir. This is the histopathology report for the patient. This is a hematox H&E stain on the right upper side. We can see the H&E stain image of the biopsy specimen. Here there is nuclear hyperchromasia is there, and coarse chromatin is present, and the immunohistochemistry was done for H3K 27M mutation, and it is turned out to be strongly positive. Stain is positive for P53 is also, sir. And so integrated diagnosis was diffuse midline glioma, H3K 27 altered, WHO grade 4. Histopathological diagnosis was high grade astrocytic glioma, final. So current clinical status is child is under regular follow-up and doing well. Power is 4/5 in the upper and right upper and lower limbs. Currently has received external beam radiotherapy. 27 cycles has been completed.
Okay, Dr. Uday, will you comment on the adjuvant therapy that you would give for this?
Yeah, adjuvant radiation, I think, has the child been planned for 54 gray in 30 fractions or more?
I think
I
he
think it
received
is
54 and 27. 27 fractions.
54 in 27 is given and adjuvant radiation therapy seems to be fine, sir. The adjuvant therapy plan is fine. So it was confirmed as H3K27M driven diffuse midline glioma. So most part of the country uh, stops with RT and then follows up these children serially and MRI scans to look at the response, um, and then supportive care. Very small number of children can also take this new drug called ONC201, but essentially it is experimental, has not shown any benefit. So adjuvant therapy seems to be fine.
So when you plan adjuvant therapy for these tumors, the radiation, how much of the margin do you give? Do you give it like for a what is
Yeah,
the
so
margin?
we consider the preoperative volume, even if it is debulked partially. We take the preoperative volume and we give 1 centimeter around this as a clinical target volume, and we give planning target volume based on what modality of radiation we are using. For example, it is 0.5 centimeters if it is a 3D CRT, or little less if it is IMRT, VMAT. And the fractionation depends on how convenient and how best we can do. Usually it is 1.8 gray per fraction, so it is fine. Uh, Thalamic gliomas previously we were using, meaning until this histone gave classification, and like how the pathologist also spoke that histone versus EGFR versus EZIP. We were giving temozolomide for thalamic gliomas and not pontine gliomas, but now even that is recommended to be stopped because it can cause toxicity and there is no much benefit in terms of local control or progression-free survival. So we prefer to do only radiation therapy even in thalamic diffuse midline gliomas, and then assess the child serially with MRI scans and then follow.
What is the present duration of follow-up in this child? When was the radiation completed?
I think the child is still going on. I think that's what they say. Has received 27 cycles means I think the child is still on radiation.
Still on
Deepak,
radiation.
Deepak, has he completed the radiation or Deepak
No, sir.
Naik?
Child is still on radiation therapy, sir.
Still getting
Yes.
radiation. Okay.
Oh. What is your idea, take on Uday on proton for this? Would you have considered proton if the child can afford?
We have treated few children, sir. We have treated few children, but these children, we have treated quite a number of children, to be very honest with you, because the families, they think that proton can do magic, and in fact, serially paired experiences of comparing proton with the conventional machine, what we have here at tomotherapy, there is no change. But only that the radiation dose, the low dose pill on the cerebellum, the low dose pill towards the contralateral side, that can be slightly reduced. And because biologically proton can give about 10-15% higher biologically effective dose, some people have tried, but the experience is extremely poor. It just does not give any benefit compared to what conventional radiation can do. And the sad part of the story is, if suppose there was a child who can be recruited in an ONC201 randomized control trial, which was called ACTION trial, which is still ongoing, children who received proton therapy were declined to be enrolled into this trial. So that also was sort of a point not to consider proton therapy. But as you know, many of these families who are in the affordable class, they wish to do whatever best possible for the child in the first go. And so we'll end up giving proton therapy. We have treated, I think, close to around 75-80 kids of which 30 maybe around thalamic, remaining maybe about pontine gliomas. We don't have any child living more than 11 months despite doing proton therapy.
You
Dr.
still
I had two
restrict
questions.
to 54 in
Yeah,
proton also?
54 only, sir. 54 only in 30 fractions.
Yeah, Dr. Uday, two questions. This is if this patient had undergone only biopsy and that biopsy has come as DMG, would you have considered decompression or directly taken radiotherapy? Another question I always had is, see, we diagnose with biopsy and then diagnose DMG, send for radiotherapy. Is that the end of the road, or in case if the tumor recurs after the radiotherapy and if there is a mass effect, is there a role for surgery in these patients?
So
Because
first
we
question,
we get a biopsy and then we refer for radiotherapy and then they don't come back, or we don't consider any surgical intervention, or unless there is a hydrocephalus for which we do shunt.
yeah.
But if is there anything at the time of recurrence for this patient?
So first part of the question is whenever feasible as a MDT discussion, if suppose the surgeon feels it can be operable and if it is technically possible with all the adjuncts of MRI imaging, then definitely debulking will be considered. And even if it is diffuse midline glioma, which we have tried in a couple of children, but whether that partial removal of the tumor will provide any further benefit in terms of local control and survival, I'm not sure if it will add, sir. So whether putting child into a radical surgery or maybe intent of removing further, whether it will help in terms of local control or no, I am not sure. First point. Second point, it only becomes necrotic after radiation. And if the first surgery was not possible when the child was more neurologically intact, when it recurs, whether that surgery will help in uh, adding more options of treatment or whether it will help in improving the neurological condition or even survival, I'm not really sure. So what we do is we tend to give second course of radiation even if the child has finished radiation 6 months ago. As of now, that's the only option available. So we have had children who receive radiation at a median age of 6 months, sorry, median age of 1 year, even at lower end being 6 months to upper end being 18 months. And those who afford will take ONC. We have tried to help them with sourcing it from France and Germany because US does not give it, although it is now FDA approved. US does not give it to other children also outside US. So we try to give. I think if the surgery was not possible in the first instance, whether it is possible in the second instance when it recurs, I am not sure, sir.
Thank you. I think we'll go to the next case. Ranjit,
Yeah,
please.
just one more question Dr. Deepak Gupta has raised about whether CAR T cell therapy is the likely thing for future.
So the problem is, I think even the pathologist will be able to say these tumors do not express T lymphocytes, meaning what is known that is that few DIPGs, which the initial CAR T case reports showed responses, were not classic DMGs driven by histone alone. They were a mixture of tumors with other mutations like BRAF or other things. So unless until they're able to extract and display that the reactive T lymphocytes can be demonstrated in the tumor, I don't think CAR T works. 3 children from our side have gone to China to get CAR T, but they failed miserably because of, in fact, they progressed while they were on CAR T in the trial situation. So far, that CAR T as well as the other drug therapies have failed. Only one thing which has shown some promise is bevacizumab. In fact, this is from Mariam Foradi's group in Cincinnati Children's Hospital from long time. So we can try giving bevacizumab when there is recurrence, reduce the vascularity, and then probably put them for a second course of radiotherapy. Apart from that, everything else has so far failed.
I have a quick doubt to ask Uday. Uday, have you seen any of these classical so-called DAPG-like looking radiologically, which are non-histone driven? Like biopsy did not show triple methylation, and
So
did they do better? Did they do better with radiation?
So occasionally our radiologist has shown that NF-driven brainstem gliomas, although will have classic picture like how it is histone-driven. These are sort of indolent compared to the histone-driven ones. So when we don't biopsy and when they have NF associations in the skin or other features in the body, these sort of are indolent, sir. Apart from that, everything else is aggressive.
Yeah, thank you. Can we have the next case and then discuss?
Yeah.
Most likely, the next case will have something similar as what we're discussing. Can we go to the next case, please?
Dr. Anand, start sharing your screen.
Yes, sir. Hello, am I audible?
Yes, please go ahead. Your screen is not yet shared. Yeah, please make it slideshow and proceed.
Yes, sir.
Go ahead.
So, good evening, everyone. My name is Dr. Anand. I'm from Satya Sai Institute of Higher Medical Science, Bangalore. And today I'll be presenting two cases. So, first I'll be starting with the first case. This is a 80-year-old male child who was class 3rd student, right-handed. The history was given by parents and he came to us with insidious onset of weakness of the all four limbs since the past 10 days, deviation of the left eyeball since the past 7 days, and drooping of the right eyelid from the past 7 days. On examination, his visual acuity was 6 by 6 bilaterally, fundus was normal, there was right-sided complete ptosis and with down and out eyeball. Left side, there was involvement of the sixth nerve as well as there was element grade 3 facial weakness. Coming to motor examination, his power on the right upper limb was 4 by 5, lower limb was 3 by 5, left-sided upper limb was 4 by 5, lower limb was also 4 by 5. There was grade 2 spasticity in all the 4 limbs, reflexes were hyper in all the 4 limbs and plantars were extensor bilaterally. Now, this question is for Deepak. What do you think is the clinical diagnosis? Possible differentials?
No, we'll go with the scan. We'll
Okay,
go
sir.
with the scan. We'll discuss after the scan.
Okay, sir. So this is a T2 weighted SAG and axial images. So shall I tell him to describe?
Yes, please. We'll discuss more management and clinical diagnosis. Yeah.
Okay, sir. So can you please describe Deepak?
So in this image, T2 axial section, we can see a homogeneously hyperintense lesion in the pons with some mass effect on the fourth ventricle. The lesion is almost entirely occupying the pons with the pushing the substance posteriorly, and there is also blockage of the ventricular outflow is there, sir. So
Can you show the contrast scan? Yeah.
So this is
Yeah.
the contrast axial.
Yeah.
So in contrast axial, sir, the region is non-enhancing and involving the entire pons.
Okay.
This is the diffusion weighted and contrast sagittal.
So there is mild diffusion restriction is there, but in the sagittal image, sir, the lesion is not at all non-enhancing lesion. Almost entire pons is involved by the lesion.
Yeah.
And with the, yes.
And there is no hydrocephalus on T2.
So what do you, Dr. Deepak? So what do you? So this is a young child who presented with the sixth nerve palsy, right? Or no, ptosis, third nerve palsy.
Third nerve, right side sir and left side sixth nerve.
Yeah, right side third and left side sixth nerve. Okay, so this young child presented with right side third and left side sixth nerve palsy, and these are imaging features. So what will be your diagnosis, imaging diagnosis, and what will be your plan?
So in T2 images, the child did not have any hydrocephalus, so will not do a shunt in this case, and The probable diagnosis is DAPG, sir, because the lesion is
Dr. Anand, can you
home
please
enhancing
the
and
scans
home.
in the
Yeah, okay, sir.
yeah that's okay. The contrast one.
Okay, sir.
Yeah, thank you. Go ahead, please. So your diagnosis is DAPG, no hydrocephalus. So what will be your plan? How will you manage this child?
Sir, in DAPG with no hydrocephalus, the best management in this child is to send the radiotherapy is a best, sir. And since the entire consent involved the surgical resection and biopsy is not a good option in this child. And since there is no hydrocephalus, need not do a shunt also, sir. So directly primary radiotherapy we can.
Okay, so you would like you made a imaging diagnosis of DAPG and you would like to refer the patient directly to radiotherapy, right? So at what situations would you consider biopsy with this or a similar scan? Are there any times where you think you would do a biopsy before sending for radiotherapy?
If the scan has some atypical features, sir, and the lesion is, if the lesion is exophytic or lesion has suggestive of any contrast enhancement with cystic lesion is there, like any suspicion of any pilocytic astrocytoma, then we can undergo for cystic decompression or biopsy of the lesion, sir. Since this lesion is entirely involving the pons, and this is very classical of DIPG. So
okay. So before we go to panelists, Dr. Nishant, you want to tell, you're there, Nishant, what we do and...
So we routinely advise patient party about biopsy, not because it may help in increasing the overall survival or prognostication, increasing the prognosis, but to know more about molecular and histological features. And of course, if there is a classic features of diffuse intrinsic pontine glioma, biopsy as such may not change overall survival. So that has to be told first. And of course, radiotherapy is the main treatment option, and only that can, though marginal, increase survival. That has to be informed. So with this prognosis, like it may take time for them to digest and process the diagnosis. But many of, at least in our experience, more than half of our parents of these patients have agreed to undergo biopsy with that hope. Like most of the time, there is a hope that it may be something else. So, so we have been successful in convincing them for biopsy in more than 50% of patients.
Yeah, thank you. Dr. Anand, what is your opinion? Because this, when we look at literature and when we listen to the experts and talking, what is told most often to us is a classical imaging feature, non-enhancing lesion in pons involving the pons, T1 hypo, T2 hyper. Radiation can be given without a biopsy. But at least in our center, almost like Nishant said, almost every child undergoes a biopsy for confirmation. But as a what will be your opinion whether we can directly refer and or you think biopsy needs to be confirmed to be done to confirm the diagnosis?
Sir, biopsy, although it
No,
can...
Dr. Anand Balasubramanian.
Yeah, see, the original reason why biopsy was not indicated was that it was thought that brainstem was very risky to do biopsy from. Now we do know that yes, we can do safely biopsy from brainstem. But the other point is it is quite classical when there is no enhancing area. So that's why the criteria was there should not be any enhancement seen. If enhancement is there, then you are supposed to biopsy because there is a chance that it could be something else. Now, I think biopsy is only indicated for academic purpose for you to document whether there's a histone-driven mutation or not. Otherwise, I think biopsy is only of inquisitive interest from the treating clinician point of view with no benefit to the child as such. So I think if the multidisciplinary tumor board meeting agrees to give radiation without biopsy, that can be done, and there is no harm in it doing biopsy without, I mean, doing radiation without biopsy. But if you are part of academic center and you would like to know how many of these tumors has shown, maybe once data comes out saying all these classical looking DAPGs, all of them are H3 mutation driven, then probably we can stop doing biopsies. In literature also that can come as a guideline in future.
Dr. Uday, your comments on that?
That we have what we have noticed is we had to analyze some data with what all the DIPGs which received protons. So if there was no necrosis and MVP, the pathologist can stop me if I'm wrong. And just histone alteration can be seen in with just grade 2 background, grade 3 background, or with MVP necrosis. So when we categorize them into cases between grade 2, grade 3, and grade 4 on histology in the background of H3K27M, although they were all put in one basket, there is some difference in the way the children without necrosis or microvascular proliferation behave compared to those with them. So maybe if we can find a corridor, and here Arvind and Dr. Chako, both of them are quite proactive, meaning pro biopsy, and we try to do biopsy as much as possible in all the cases, except child is quite moribund, has lower cleaner palsy, and can really become sick in ICU. Unless until it is that a walking patient, we generally try to biopsy. One observation was this, that histological grade with histone background also can help. And other is it will also add on at also very few occasions we have tried to do NGS on this and try to see if there are other rare mutation. In a girl child, we found that there was a HER2 amplification. HER2 amplification, which is seen very rarely. And we ran it through the national DMG of US, and they also had seen some HER2. So we tried giving, I know Nishant has got a talk now, but still we tried to give the oral TKI inhibitor against HER2. It didn't make much difference, but then it was possible for us to do it because we had a sample of tissue. So I think taking a biopsy and trying to do whatever best we have in our hand is a wise decision on day 0, because something may come up in few months or maybe in 6 months, 1 year, and we may be able to try on these children, although the prognosis is very, very less. That is my take.
Yeah. So if we go by the literature and consensus, they say classical imaging, direct radiotherapy. But we have had that is, I've raised it many times. We have had challenges where a biopsy is often sought to confirm diagnosis. So this is for general neurosurgical community, as the residents are listening, and this will be there for them to listen. What are the chances that our imaging diagnosis can be wrong, and later we are found that we have given radiation without a diagnosis, without a histology? And if the chances are reasonably high, what are the atypical imaging findings that will help us if we decide that we don't have to do biopsy for all these lesions? What are the red flags or atypical findings that we should remember to look for, which should mandate us to do a biopsy before radiotherapy? Dr. Uday, if you are asked to give radiation upfront, what are the imaging features that you would look for? And if you find them, you'll say, no, I want a biopsy before radiation.
Like any other abnormality in other parts of the brain, like very occasionally phases or any cutaneous manifestations, to say this is not classic histone driven or aggressive DIPG, or if there is cyst and solid. And what occasionally we have discussed in our MDT is a classic DIPG should have full encirclage or almost full encirclage of the basilar artery. If that is not there, or if the disease is more towards CP angle or more like a peduncular disease than proper Pontin disease. And in our center, Adi does this APT ASL mismatch. So he does ASL and APT, and he tries to see if the areas of perfusion by these two different sequences are same or discordant. So these are few things what I have learned after coming here, which we make sure that we take a biopsy and we decide, or if a child is absolutely fine, doesn't have any manifestations, it doesn't have tenular palsies or long tract signs or ataxia, and just walked in with an incidental diagnosis of something in the brainstem. In these situations, I think we make sure that biopsy is taken and then we treat.
Yeah, I think these are very valid points. We have to remember, though we say we can refer to radiotherapy, I also concur with you. If the lesion is enhancing, if it's got 60 component, if it is not in midline, if it is more towards lateral and involving peduncle, then I would also consider more, even sometimes a pilocytic astro than DMG itself, and it would warrant a biopsy if not a decompression. So we should be aware that the imaging features, unless they are really classical, cannot be taken, and if there was a need for biopsy, I think that should be considered. Otherwise, classical imaging features, probably the oncologist will accept for radiation. Dr. Anand
Can I
Balaswamy,
comment?
any last comment from you, and then
Yeah, the only comment I wanted to make was what Uday said about. I mean, if it's of course their own personal experience that grade 2, 3, 4 histologically doing differently, maybe marginally, but that's why the
Their audio is not clear, sir.
Voice is breaking.
breaking.
Yeah.
Am I audible
yes,
now?
sir.
Yeah, better, sir, better.
Better? Yeah. No, it just said that grade 2, 3, or 4 histologically with the histone mutation, the very purpose of WHO defining it based on histone mutation was that it is directly grade 4 if it is histone driven, irrespective of histology features.
Yeah.
So whatever difference we see was observed clinically, maybe marginal, but all of them are too abysmally bad once they are histone driven.
Yeah.
Okay.
Agreed, sir. We
Thank you.
actually found, I'll just finish it one comment. Two people at ages of 28 and 30, we did a biopsy and there was IDH mutation in them. We actually cross-checked with Geeta Chako madam also, because one was from CMC.
See, that is see the adult ones, the older ones, more than 15 years, are a total different set of tumors probably. The younger ones typically within that 5 to 8 years age group with DIPG like morphology, histone driven, they don't survive beyond 10 years.
Yeah, agreed, sir. Agreed.
Yeah,
Okay.
that has been our experience also.
Yeah. Now, can you tell us what you did for this patient?
Sir, this patient was referred to an oncology center for direct radiotherapy, but due to his illness, he was not able to survive for more than 1 month and he did not start RT. He was waiting for the same.
Okay.
No, waiting, you mean to say RT waiting time?
Yes, sir. They were actually not financially that good. In that time, they were trying to arrange the money, sir. And in that, only it
I
happened.
think that should not happen, because Nishant and me, we have strived to make sure that these kids at least get a minimum of radiation, and we make sure at least we gave our cell phone numbers to these families and told, please come directly to us and meet us. Please make sure this doesn't happen, because I don't think even Kidwai is so busy that they can't afford to start on a basic machine and then convert it into another plan later. So I think you should probably talk to one of the consultants directly when you're referring, and make sure that at least radiation these children receive.
Okay, sir.
No, I know, sir. Dr. Deepak, I know. I have worked in Kidwai, I have worked in TMH and CMC. So waiting time is common, but then we have to stratify and make sure that these children are seen on priority. These children, we can start on parallel opposing fields on telecobalt. There is no need of IMRT for these children. So parallel opposing fields on telecobalt, it takes only 1 day planning and next day start. So I think that has to be stressed, and there is no point in putting more pressure on the consultants of radiation oncology to start it as early as possible. And like how we start any other palliative care situation, we have to start immediately. I don't think waiting time of a radiation oncology center can be an excuse to start radiotherapy for a child with DIPG. But one thing what we have noticed is, Nishant also will agree, few children drastically improved. They improved so much within few fractions of radiation and within a month of or maybe during radiation, that we were quite surprised. And although they also eventually progressed, so that was quite encouraging. So that's what kept us pushing to do more and more as much as possible for these children. And delay in starting RT is absolutely no excuse, please.
Yeah, I agree. I mean, because these children have that's the only option available, nothing else is available.
Yeah.
So, okay. Thank you, Dr. Deepak. I think we'll have only one case from each of you because we have to go for the next talk. Now I'll invite Dr. Nishant to uh, give his talk on management and newer therapies. We'll
Thank you,
have
sir.
to be mindful of time, and we'll close at 8:30. Thank you.
So, can you see my screen?
Yes, Nishant, go ahead.
So I'll straight away start off my presentation. So brainstem, I will be more concentrating on though the topic is diffuse intrinsic diffuse midline gliomas, I'll be concentrating more on DAPGs because that makes a larger part of DMGs, especially in pediatric population. So brainstem gliomas form 20% of pediatric CNS tumors, and DAPGs form 80% of those brainstem gliomas. They are rare, extremely malignant, and diffusely grow in the pons. Median diagnosis is done at 6 to 7 years of age. They usually present with acute neurological symptoms with classic signs of cranial neuropathy, weakness, and cerebellar signs. Hydrocephalus is seen in around 10%, and the most devastating thing is the prognosis is only less than 1 year, and 2 year survival is less than 10%. So the magnitude of DAPG, like if you compare with the incidence of these cases in other countries, and if you correlate with the Indian childbirth and population, it may be approximately more than 1,200 cases per year. That's significant. So diagnosis primarily is based on histology, neurological examination, as well as imaging. All three has to be correlated. They usually are expansile, infiltrative, involve more than 50% of the pons. MRI T1 hypo, T2 hyper, flare homogeneous, rarely enhanced. Enhancement can be there, but irregular enhancement can happen. Basilar artery encasement usually reaffirms that it is DAPG, and infiltration of cerebellar peduncles or to midbrain or medulla is very frequent. Spread leptomeningeal dissemination can happen approximately in 40% of the cases. These are autopsy studies, so these might have recurred, especially after radiotherapy when there is progression, especially after recurrences after progression. After radiotherapy, they will have more leptomeningeal spread than initial occurrences. Pathology, usually they are astrophytic morphology. They grow diffusely among neurons, invade to adjacent structures. Histological grading, as already discussed, whether it is whatever grade it is, necrosis, whatever types of histological picture is there, it doesn't predict outcome. The most important thing is H3K27 mutations. Those dictate the outcome. So we can see in the PubMed timeline, you can see that there is an explosion of studies after 2011. So that is when the landmark study published identified a pathognomonic H3K27 mutation in nearly 80% of DAPG cases. What happens is lysine is substituted with methionine, and there are two isoforms, H3.1 and H3.3, and there is a strong nuclear staining which can be easily seen, which is not present in vasculature but only in the tumor cells. Therapeutic options, the only proven significantly prolonging survival, that too meager, is radiotherapy. Usually 54 to 60 grays have been advised over 6 weeks, though hypofractionated regimens have been studied in patients who are not doing well. Dexamethasone, though temporarily they alleviate and stabilize neurological symptoms, can be or should be used when patients have been deteriorating. And no proven chemotherapeutic agents are there which have prolonged the overall survival significantly overall. So, as Uday may agree, the risk of brainstem injury is happens only if we give radiation more than 64 gray in length. So it is also noted that 85% of patients have clinical response. That means they improve in their facial weakness or generalized weakness or in ataxia, and 50% of the patients show radiological response. Typical, this is a picture of our own patient who had a good response after radiotherapy, both clinical as well as radiological. But as soon as radiotherapy is over, approximately in 1 to 4 months, tumor progression happens. There is a rapid clinical deterioration, and death may happen sooner. So re-irradiation, several studies have proven that there is a small survival benefit, but especially if there is a rapid clinical deterioration, radiotherapy can improve quality of life in case of recurrences also. Prognosis, overall survival is 30%, around 20% at 1 year, 10% in 2 years, 1% in 5 years. We have to be mindful that this overall survival has been in historical studies where H3K27 mutation was not routinely done. So, with H3K27 mutations, the overall survival, even though earlier told 10% at 2 years is a bit too much. Like it has to be taken with a pinch of salt. So clinical trials, what has been done is everything but a kitchen sink has been thrown at it. Existing alkylating agents which are used in other tumors, biological and molecular pathway inhibitors like erlotinib, tamoxifen, bevacizumab, radiosensitizers, immunotherapy, anti-angiogenic therapy, everything has been given, but none of these have shown a significant overall survival benefit. Why? So the long-held assumption that pediatric DAPGs may be a similar counterpart of other gliomas in adults. That has been proven that it's not the case. They differ markedly from adults. There is a poor understanding of molecular and cellular biology. Still now, we are struggling to find out what is the pathways in which tumor develops as well as progresses and spreads. There is underappreciation of tumor heterogeneity, like how we have understood in cases of GBMs, tumor heterogeneity has not been much studied. Lack of representation, because most of the institutes don't do biopsy. There is a lot of lack of understanding on studies which have been done on tumors. So, what are the barriers of progress? What is stopping us from giving proper treatment? Because surgical morbidity can occur if we try to do surgery or take a lot of tissue. Infiltrative nature, resection or total resection is impossible. Absence of effective drug treatment so far, and lack of primary tissue so far, which has been changing with growing change in increase in biopsies, especially in institutes. So there is a call for biopsy. Since almost 10 years, there are a lot of studies who have shown there is effective as well as increase in yield rates, almost more than 95% success diagnostic yields in multiple studies, which with less than 10% of transient complications and 0 to 1% of permanent complications, and no deaths have been reported, at least in larger studies in institutes. So other indications, as well as this was discussed earlier, if there are irregular characteristics, there are points which tell that it may not be DAPG, and in institutes where they want to study biomarkers or plan for targeted therapy, these are indication of biopsy. So with this invasiveness of biopsy, a lot of studies have also been done using liquid biopsies. Ultrasensitive droplet digital PCRs have been done so in CSF, both to detect as well as track DNAs up and down, which happens during treatment. Though it doesn't correlate with the size of the tumor, it correlates with progression-free survival. For example, if there is a good response after radiotherapy, usually this circulating free DNA decreases, and that indirectly tells that if there is a trend of decreasing circulating DNA, it tells that patient may be having a better prognosis compared to patients who don't have good prognosis. There are several barriers because we have to do LP in a child, and the time taken for the reports of this circulating DNA is almost 1 to 2 weeks. We cannot wait for treatment until that much time. So molecular characteristics, pathognomonic is H3K27M mutation. There is substitution of lysine with methionine. We all know that mutation leads to histone trimethylation and with inhibition of polycomb repressive complex. But the precise role, how H3K27M causes tumorogenesis is still elusive, but though several mechanisms have been proposed. As we all know, there are two variants, two subgroups. H3K, H3.3 has 3.1. H3.3 has worse prognosis, lower response rates to treatment, as well as more metastatic compared to H3.1. Other typical mutations which we have to know is ACVR1 mutation, which occurs in 30% of DAPGs, which happen more in younger tumors, as well as it causes poor prognosis and early tumor progression. T53 mutation can happen approximately in 1/3 of cases, along with usually it happens with PDGFR amplifications, as well as PPMI1D mutation, which can happen in almost 1/4 of tumors. So, with this much of knowledge until now, there are several therapeutic strategies employed. Pinabinostat is one agent which has been tried, which is a histone deacylation inhibitor, HDAC inhibitor, which has been used alone or with many other treatments, like for example with everolimus, with convection enhanced delivery, with blood-brain barrier, with low frequency ultrasound. All this has been studied. It has shown marginal improvement in overall survival, but though it is not statistically significant. Several cell cycle regulators have been seen, especially CDK 1, 2, 3 have been shown that alone. These have shown that inhibitors can be useful, but this has to be combined with other agents to show whether it can be useful meaningfully. So other ways in which it has been seen is whether we can reverse the hypomethylation. A reversal of hypomethylation can also is also studied by demethylase inhibitors. Like for example, in one molecule called GSK J4 inhibitor. So by demethylase, this by causing inhibition of demethylation, it will indirectly cause increase in genotoxicity, as well as it has shown to be slightly more radiosensitive, increase the radiosensitivity of the tumor. So inhibition of EZH2 has also been studied, which is very important in the pathway. It binds with polycomb repressive complex, and the inhibition of that also has been shown alone, as well as with other molecules, which has shown some promise in studies. The latest kid in the block is ONC201. There are other congeners like ONC207, which has been used alone as well as in combination with other drugs, has shown overall response rates in around 20% of the people. So we have to be mindful that just by treating this will not be enough. We have to combine with, or we have to selectively select patients based on some studies in the future who will be responsive with this target. Other targeted therapies have been used for various agents, but radiation therapy has been a gold standard, but fractionated radiation or radiosensitizers have shown no slightly less benefit. Several trials are still going on. Re-irradiation has definitely shown that clinical improvement can happen and improve the quality of life. Already somebody asked about CAR T-cell therapy. What CAR T-cell is, it is a T-cell with a receptor which has an antibody which acts against the antigen which is present in the tumor. For example, the most common target is GD2, which is present in the tumors. So it has shown promise, but there are a lot of side effects. For example, if you CAR T-cell therapy can be given by convection enhanced therapy or through enhanced blood-brain breakage. But what happens is there is a lot of reaction. There is a lot of immune reaction which happen in the local phase. What happens is, as soon as you give it, patient deteriorate because of a reaction or immune reaction which happen in the local phase. Majority of the patient develop acute hydrocephalus, and if that is solved, for example, how to control the immune reaction, that will solve how this side effect can be sorted. So the several studies have shown how to impede blood-brain barrier. For example, if you can give drugs through intranasal delivery, nanoparticles, focused ultrasound, especially low-frequency ultrasound, convection-enhanced delivery, as well as intra-arterial delivery have been tried. Now there are a lot of trials which are going on with low-intensity ultrasound with ALA, doxorubicin, and several other molecules have been tried. I will show briefly a few of our examples which are published. We recently published a paper with 92 patients, of which 47 was biopsy. It is important to know in our setting that even though we kept a close follow-up, adjuvant therapy received in only 60% of the patients. That there are various social factors which dictate this, which is very important, and we cannot compare our data with data from Western publications just because of this. So there are various different locations. It can spread to either cranially or caudally, and approximately 42% of patients required CSF diversion, and our median overall survival was 7 months, and adjuvant therapy was given in 60%, as I told you. But prognosis wise, I can tell you that in our study, the only thing which made difference in prognosis was adjuvant therapy. Patients who didn't receive adjuvant therapy had a rapid decline, and it was the outcome was bad sooner. So this is how in a patient who received biopsy as well as radiotherapy, initially there is decrease in radiological decrease in size of tumor, but over time, after 18 months, there is cystic change, necrotic change, and then patient usually has deterioration in clinical as well as radiologically. So we did our own analysis of efficacy of biopsy in diffuse intrinsic pontine gliomas. Our diagnostic efficacy was almost 95% with transient complication of around 11%. This is how we do. We use under GA with frameless biopsy. This is using a Medtronic navigation system. We go transcerebellar, middle cerebellar, cerebellar peduncle approach, and we can do live tracking, and we can take biopsy. The same thing can be done in brain lab system also. And a few cases where there was a lesion was extending to the midbrain, we have done frame-based biopsies as well, mainly in adults. So this is how the biopsy was done, and you can see the telltale signs of biopsy here. So it is important to know that there are some though the patients can have complications, majority of them are transient. One more thing I wanted to stress upon is you can see here there are 4 cases in pediatric patients who had a different diagnosis. For example, in astrocytomas, two patients had pilocytic astrocytomas and one patient had ETMR. So without biopsy, we would never have known that this is the case. Though the percentage of patients who will have an alternate diagnosis is higher in case of adults. So across studies, it has shown that the diagnostic yield is more than 95%, and transient symptoms after surgery is around less than 10%. So we also have published the thalamic H3K27 altered diffuse midline gliomas, especially in pediatric population. The medial overall survival was 7 months, and in adults it was 8 months, with or without surgery. And adjuvant therapy was the only factor which increased the survival. And we also have unpublished material of 47 adult patients who are prospectively followed. Diffuse intrinsic pontine gliomas, according to the images, out of the 47 cases, we could biopsy 35 cases, out of which 15 were actually non-H3K27 mutated patients. And of course, patients who were non-H3K27 mutation had a higher survival, which was 17 months. And we have 4 long-term survivors out of the 15 patients. And even though long-term survivors were present more in adults, the median overall survival was 17 months in adults as well as in wild type, and around 6 months in H3K27 mutated patients. So we can see here in adults, we had 1 pilocytic astrocytomas, 4 grade 2 gliomas, 9 grade 3 gliomas, 1 GBM, and 2 negative biopsies. So I would like to end with a note that this much increase in literature as well as increase in knowledge about this disease is just because we kept on doing biopsy and kept on doing studies. Even though if you want to plan a targeted therapy or patient in the future, if you want to contribute for either extended survival or finding cure for this patient, the only thing as a neurosurgeon I can do is biopsy and push towards research in this field. Thank you.
Yeah, thanks for that nice presentation, Nishant. I have a few questions myself, but we'll take questions from any questions from the audience. Uh, you can add to the chat box, or you can answer, or you can ask. Any question from other panelists, from pathologist, Dr. Rima?
I had a question for Uday. Do you do craniospinal or only you do brainstem only radiation?
Sir, we do brainstem only radiation in the immediate upfront adjuvant setting. But like Nishant showed, many a times the patterns of failure is disease spread even in the posterior fossa, even in the supratentorial brain or in the spinal cord. In those times, if the DFI is more than 12 months, then we consider craniospinal radiation, but very occasionally, sir.
And Nishant, in your subset adult, you showed wild type. Pediatric, how many were wild type?
Sir, I think it was some 5 patients. One was ETMR. That patient had a rapid decline and expired because the overall prognosis in ETMR is as such is bad. There were one patient with a pilocytic astrocytoma. Like it was occupying the whole brainstem. And though we did biopsy, even that child was very young, like 1.5 years or 2 years old. That patient had even before taking, we thought we'll give radiotherapy, but child succumbed before that. And 2 patients with most of these patients who are IDH wild or they come out to be IDH mutant, HDK27 wild, but IDH mutant gliomas. Whatever 3 or 4 cases are there are at the age group of 15, 16, nearing adult rather than less than 10 years.
I think these things will require more workup with methylation profiling or something, because they are very bizarre and non-classical location appearing tumors. Very difficult to characterize them based on just these few molecular markers.
Exactly.
So,
yeah. So, like, what the starting point of our study was a radiological as well as clinical DAPG rather than starting out as a HDK27 mutant gliomas. So, our inclusion criteria was radiologically for more than 50%, predominantly in pons, presenting with acuity with this thing. So, in those cases also, there were 5 or 6 patients who were outliers.
I think all your samples of these radiological DAPGs which you have done, you should try to get a methylation profiling done and see how they turn out, especially at least the wild types.
Yeah. So I think like in the future, at least the DAPG samples should undergo both profiling as well as NGS for there are so many targets which have been described. I think though not now, in near future, targeted therapies may come. So if we know what can be targeted, especially there are a few things which can be targeted right now. So NGS profiling will be a good option to look forward to.
Yeah, actually, we have been doing biopsies for a long time on these patients. Most of the times, biopsy and not referring directly. And Dr. Nishant showed both papers. One paper, I think, in early 2010s, last decade, and one recent. My interest is looking at the diverse pathologies that we found. And how the diagnosis evolved. I think the first paper, when Manoj's paper published, I think 2011 or 12, that time there were no concept of H3K27. So if you look at that data, where again it was all brainstem lesions which are biopsied in children, nearly 8 to 9% were not glioma at all. And even in glioma, there were reported as grade 2, grade 3, grade 4. So that I will request the pathologist to make a comment. And many of them now, even though were reported as grade 2, now would turn out to be H3K27 mutant. So now he showed the latest, our recent cohorts patients pathology, where you can see we are not just giving importance to only the grade, WHO grade, but also the molecular data. So this is being possible because we are able to analyze not just radiologically but also pathologically. It gives an insight that there can be conditions which are not necessarily a DMG, though it may look radiologically a DMG. This was always our thought process in the background to convince ourselves also to do biopsies in all these patients or most of the patients, and also justify and talk to the patient's relatives, say that you would require a biopsy, and then based on that we can proceed. Then Dr. Nishant, can I show the table of the pathology table? It is
Hello,
There
am I
are two,
audible?
sir, actually.
Yeah, Dr. Rima, please go ahead.
yeah, correct.
Yeah, question to Dr. Nishant. Sir, in the data you have showed, there were 20 cases of H3 wild type, no, sir?
Yeah,
Adult.
in adults, there are 15 out of 43 which we have biopsied.
Okay, 15. And all these
35
15 are
biopsied. Yeah.
further characterized.
Yeah, that's what I was about to tell. So for example, how you have told that further testing is required in cases. That's why I asked you one question in earlier, that what are the things which we have to do if HTK27 is negative. So at least when we were doing this study, only HTK27 mutation were poorly analyzed. Further,
Okay.
EZHR, all these things have not been done in, at least in these cases, which can
Okay.
be positive even in these cases. 100%. Yeah.
Okay.
So
So
in this,
now
almost
in
30%, 30 to 40% are not H3K27 mutant. They are grade 3
This is
IDH
adult.
mutant,
This
grade
is
2
adult.
IDH mutant.
yes,
Right.
and the molecular profile also varies very much between adult and pediatric population as well as between location. But currently, if a tumor is H3K27M negative by immunohistochemistry, the next thing we have to do is an EZIP immunostain.
Correct.
Then if the EZIP is also negative, then the next wiser option is to go for a wider molecular profiling like an NGS. NGS will not only give you the mutation, as well as you can get some clues about targeted therapies. That is one thing. And another thing is there are some other group of like your diffuse H3 wild type, IDH wild type also can come in the midline location. All these things can be picked up in your NGS. I mean, those mutations associated with those kind of tumors can be picked up if you have a broader panel like an NGS or a methylation profiling. So that's how the workflow should be IHC. If not any pediatric high-grade glioma, it's better to go for an NGS if the initial IHC panel is inconclusive. Methylation profiling, it's not widely available in India for us to comment that.
The tissue sample, what we get in the biopsy, will it be enough to use it for so many things? Because
I
at
think
day one, I think from the
NGS will
table of
require.
biopsy, we should decide what are we going to do.
That is true,
Because
especially in a bithalamic one, where there is EGFR mutation is common compared to other locations. And our EGFR alterations, we are not going to pick up by your routine immunostains. All those scenarios are the nature of and the amount of tissue, everything matters a lot.
I think we should close now. We are just going past the time. So on behalf of INDSPN, I thank all the panelists and the speakers as well as the residents for presenting the cases and making it a very interactive session. Dr. Deepak Gupta, are you there?
Yeah, I'm there. Yeah, no, thank you so much, everybody, and thank you, panelists, moderators, and the presenters. And thank you, Harry and Ranjit, for hosting such a good show. And I think with this, I want to make a very important announcement. In the month of July, 24th to 26th of July, we will have a midterm conference of Indian Society for Pediatric Neurosurgery, and the theme this year will be on neuro-oncology. And I hope many of the people who are present here, we had a very recent gathering today. I think 50 plus people were joined online. And so I hope to see many of you in July. Thank you so much. And I think with this, we close the meeting.
Yeah, thank you very much. Thanks
Thank
everyone for joining us.
thank
Thanks for the
you.
great
Thank
discussion
Bye.
and presentation. Thank
Bye.
you.
Bye. Thank
Thank
you.
you
Thank you,
for giving
Anju.
us the opportunity. We're signing off from
Thank you.
Health NU.
Thank
Thank
you.
Thank you.
Good night.
This webinar will be available on YouTube, DigiNeuro tomorrow, and a copy also will be sent to INDSPN.
Thank you. Thank you. Thank you, sir.
Yeah.
Thank you.
Thank you. Thank you. Good night.
Good night.